afternoon, everyone, and welcome to this webinar today. My name is Vanessa Pierce, and it gives me great pleasure to introduce Managing Private Patient Services during COVID-19. I'm so thrilled that you're able to join us, and I'd like to extend a special thank you to Streets Heaver Healthcare Computing for sponsoring this event. It gives me great pleasure to introduce Kim. She is the Private Patients Manager for Guy's and St Thomas's Private Healthcare Services.
Okay, well, good afternoon, everybody. I'm Kim Foord-Paton, the Head of Private Patients at Guy's and St Thomas's. Thank you for joining us this afternoon. So we've been asked if we could just give an overview of life through the pandemic and following on from our 2020 conference. So if we just start off with what's happened since the 2020 conference that we held at Guy's and St Thomas's back in March time. Obviously the COVID has struck and we were closed down from the end of March onwards. We handed back all of our private patient facilities, as did many others, to the NHS services for them to run their practices. All of our staff were redeployed into different areas. So we had the nursing team. A lot of our nursing team went to intensive care and were retrained into a different skill set to be able to support and run the service, the NHS services, in the influx of COVID positive patients that we had. For us, that was, and our staff, that was quite an emotional and draining time. They went through it with positivity, but at the end of it, it was quite emotionally draining for both the clinical and non-clinical staff, and left them quite nervous moving forward into the second phase that we're currently going through at the moment. So as a trust, we decided we needed to do something to support our services, and Siobhan is going to talk to us a little bit later on about the health and wellbeing and support that we've introduced there. So how did we regain our services? So that, again, as I'm sure for the rest of you, was a big struggle. It was very conflicted for the trust, as in we were in a situation where all of our private patient revenue that came to the trust was completely wiped out. So there was no income, or very, very little income coming in. We had a small amount still coming through our paediatric service for international patients that were already here and were partway through their treatment. So we then had to have conversations with the board and with our tactical recovery groups around how we would do that. So between myself and Mark, our clinical lead, and Adam as our medical director, we had those conversations, and it was agreed trust-wide that there needed to be some sort of financial recovery program, and private patients obviously was the key point for that. So we gradually regained our services. We started off with getting our outpatient services came back, followed a couple of months later with our inpatient ward being returned to us. So we had the negotiation and agreed that we would have our ward facility back, but we would still accommodate and service some overflow NHS patients that needed to come for procedures but weren't COVID positive, and that we could do so. So the current state of play, how we're operating currently, is we are back to our full services for outpatients, and our consultants can use those facilities. Inpatient wise, we are back to about 40% capacity, where we have the negotiation where we do part private on our wards and part NHS. And that seems to be working extremely well. The consultants are quite happy because they're able to do some of their private work again, and it's aided us to help with the financial recovery, beginning that process. For us, things have slightly changed. It's a new way of working. And for many of you, as you will know through various news items, we are due to merge as a trust with the Royal Brompton in the new year. So we are looking at ways of how we can work with our private patient units together moving forward in the new year. So that's going to be something very new for us as a trust. We are getting busier, and it's about how do we still provide the service for the private patients and grow that business, but with the understanding that there has to be some support mechanism still there for the NHS services as we go through this COVID situation. We are one of the main trusts that are going to be delivering the vaccination, the new vaccination. So again, from this week, that has been a new thing for us to be able to support and look at how we can help the trust with that as well. And Siobhan has been asked to help lead the way forward with that. So she may also tell you a little bit about that as well. So that is currently where we are. I will now hand you over to Mark and Adam, and they will talk you through getting back our services and some more insight into the private patient delivery currently. So Adam and Mark, do you want to turn your cameras on and unmute yourselves, and I will hand over to you.
Hello, thank you, Kim. So, hello everyone, my name is Dr. Mark Ibrahim. I'm a consultant anaesthetist and the clinical lead for private practice at Guy's and St Thomas's. I've been asked to talk to you about bringing patients back for us to our PPU and for you to your private hospitals, I imagine. So I'm just going to get the clock to make sure I don't overrun. And we're going to move on to the next slide. So, as you know, 2020, before COVID, the NHS was operationally really struggling, and it was the worst operational performance since 2010. Now, on top of that, we've had a dramatic drop in elective activity, which is what you've seen. And privately, most PPUs have been taken as part of the COVID response. And talking to colleagues outside of my trust, we're one of the few ones that have actually managed to retain some of our ward footprint. Going forward, what are we looking at? We've all lost processing capacity, no matter which sector you're in. We're all looking at a lot of extra expense to deliver the care, both in consumables, staff, and loss of productivity and efficiency on all the pathways. Probably looking at 3 to 5 years before a full return to normal. And in the meanwhile, we have to try to deliver extremely complex healthcare in what's going to be a very changeable landscape. Bit of the wider economic context to consider. GDP drop is going to be somewhere between 8 and 11%. Most of the articles talk about 5 years of economic scarring. Unemployment to rise to 8%, which is a conservative figure. Now, that's important because a large part of the private medical insurance is corporate. So with these companies downsizing and looking to sort out their bottom figures, the rate of PMI on a corporate basis is probably going to drop. On top of that, individuals have different ways of working, so they're in different places, and we're going to have different ways of working. So our established ways of generating activity are going to be disrupted. Add on to that as well, we're going to have probably imminent and significant tax rises, if not in this budget, then the next. And then once we've got over this once in a generation economic hit, we're 4 weeks away from our second once in a generation economic hit. The NHS and private is not immune to this, so it's going to be a very challenging economic environment. What's my feeling? There's going to be a lot more work available, but there's going to be less money to fund it. I can't foresee the picture looking in the short term, which I would define as 3 to 6 months. But I think the medium and long term for encouraging your patients back is looking very, very promising. The discussion with my peers, there is a feeling that in the midst of the chaos lies the opportunity. So many of my peers have been long established relationships with the private hospitals. These have been disrupted. And as a PPU, we've managed to get some people to consider using this and start using this when they've not been previously. And this is based on the disruption of that previous relationship. So what is the opportunity? You've got this huge backlog of patients, and that is private as well in some cases, but you've got a huge backlog of NHS patients. The waiting list of people waiting more than 18 weeks to their treatment is has tripled. It's the longest and highest number of year-long waits since 2008. And as of June 2020, the average wait time once somebody was declared for treatment was 6 months. The NHS Confederation has declared there will be 10 million on the waiting list by Christmas. Now, if you now combine this with the fact that overall healthcare capacity has been decreased because some NHS work is happening in the private sector, and the loss of productivity and efficiency by the multiple pathways, then you're going to see that this work is not going to be serviced quickly no matter what we do. Now, on top of that, the last financial crisis told us that lots of people will seek self-employment, which is typically the source of self-pay patients. So we've got this huge backlog of patients, difficulty in doing it all quickly, an amount of work you can't do quickly, and more people looking outside of the NHS. So how are you going to attract patients to your private patient unit or to your private hospital? Well, I think the first thing is going to be public-facing measures to instill confidence. You can't take this too seriously. About 3 weeks ago, I had a colleague who's had their privileges in a private hospital suspended because they did not wear adequate PPE in clinic and in public spaces. The hospital was not willing to have anybody undermine its message of safety. Strict adherence to the principles of infection control at all times, in all places. Then you're going to need to figure out what you can do and then start to communicate that with colleagues. One of the big lessons or big points here for the private sector has been the damage that's been done to relationships between hospitals and consultants. In March, April and May, you had the initial hit where consultants with long-term patients essentially had nowhere to treat their private patients because of the almost complete consumption of the private sector by the NHS contract. That caused a lot of upset and a lot of angst and a lot of difficulty. As we go past May into June, July and August into the recovery, what we found was that unless you were a really big hitter privately, the medium and small size practices, they lost their regular operating slots, they lost their regular clinic slots, and the hospitals that did not communicate well and try to build relationships with those consultants, try to find ways to deliver the care that needs to be done, ended up damaging the established relationship. What does this mean? It means that a lot of consultants who have established ways of working are very flexible at this time. And if you can communicate and problem solve with them and find a way to deliver their needs, there will be good opportunities there. In addition, the rise in self-pay, which was predicted before COVID, is probably going to continue. And so the availability of financial packages are going to be important. New ways of working will help you attract new patients. And then to attract your volume of work, approaching people on the NHS waiting list. This is a really tricky point and one that causes a lot of heated discussion when I discuss it with anybody. Specialities are going to struggle more than others, and some are probably going to start to offer less. And when they do, the opportunity to pick up that work will exist. if I was to consider the most sensitive way to do this within an NHS trust, it would be that when somebody is decided that they're going to have treatment, that a simple one-liner on the letter explaining that they can fund is an option. But this is something which is going to be a very hot topic. So if you're going to approach this, please do with caution. Your usual marketing, I've seen a massive rise in my personal practice of the amount of times I've been asked to quote for self-pay work. Normally, I have foot and ankle and fertility work. My foot and ankle surgeon will do 3 or 4 self-pays in a year. I don't have 3 or 4 in the last month alone. So I think there's a change coming. On my social media, I'm also seeing the big hospital chain promoting their self-pay and the hospital groups coming together with the financial teams to turn around self-pay packages in a number of hours if possible. So what have we done? Well, Kim's gone through it very, very nicely. We've publicly reopened, welcomed our consultants back we can. We've tried to reach out to the organisation and try to help where possible. We're putting the private income as a source of economic recovery. We are maintaining consistency with the pathways of the hospital. And then where things are tricky, that individual consultant support, our team has tried to do and has done very well, so that we're able to deliver the majority of requests in a timely manner. So as Kim said, we're back on our feet, but we're not quite to where we were pre-COVID. Thank you very much.
Thank you, Mark and Adam, for that. Adam, is there anything that you wish to add? Now we have you on camera.
I feel like a real fraud. We just sat in taking any credit for that, which it was a presentation we worked on together, but delivered beautifully as always by Mark. But no, I mean, look, I guess my reflections would be on a very personal level, alongside my work at the Trust, as well as having my own private practice, and have seen a remarkable array of different responses to this. In fact, what I found a little bit surprising is that some people absolutely just shut their practices down and have barely even started them back up again, whereas others have been able to maintain their practice throughout the whole pandemic. What was really apparent was the different way that different facilities stepped up to try and manage this, with some facilities managing to stay pretty much open and operating, and others closing down in late March and still not up and running again. Including some of the HCA facilities I've been involved in, which is a little surprising, I guess. But I think my takeaway was that with a positive attitude towards being able to deal with all this, learning the lessons from speaking to lots of people, seeing what's happening in NHS hospitals, it really is possible to pretty much get back and up and running again. And certainly I've seen some nice examples of that.
Okay, thanks, Adam. So Adam and Mark, and Laura, hello Laura, if you want to turn your cameras and microphones off, and then I'll introduce Siobhan. Siobhan, if you can turn your camera. Hello, afternoon, Siobhan. So I'll now hand over to Siobhan, who will talk through staff health and wellbeing during COVID-19. And I've dumped a little surprise on her this afternoon. She might even tell us a little bit about the vaccination programme that we are looking at running there. So I'll hand over to you, Siobhan. Thank you.
So good afternoon, everyone. I'm Siobhan McTague, and I'm the Director of Nursing at Guy's and St Thomas's in the Commercial Division, which is where the portfolio for private patient services sits. So I have some clinical oversight of the service, and it's a joy to have some patient contact through the private patient service. So I'm going to talk to you this afternoon really about what we did as an organisation for our staff wellbeing programme through COVID-19, and indeed what we continue to deliver today to our team and our people. So the pandemic arrived finally. I guess many people had thought there was a pandemic would come, but we thought it would be flu. But I guess nobody really planned for the ferocity and I guess the insight we would have seen from China and from our European friends in Italy and Spain, particularly where they were hard hit. So as I guess the days ticked closer and we realised the virus was in our country, and we knew we were going to have a surge, and we knew there was going to be a lot of people to look after and to care for in the organisation and indeed across the country. It was quite scary. So even people that had a lot of experience dealing with terrorist attacks and major incidents before, this again was another level of kind of planning and anxiety. But we have lots of experience and lots of good people in our organisation, and the high level planning started pretty early in the year. All of that planning and all of that preparation and how much training doesn't really leave staff prepared, and indeed some of the anxieties and the emotional distress that people have experienced through this whole year in 2020 is what we really aim to look after through the pandemic and in the longer term for them. So people thought they could be there and see it all, and there was some heroic kind of work patterns, and people needed to realise then this was a marathon and not a sprint. People needed to support one another and really show camaraderie across professional groups, across pay bands, across departments, and they were really good things that people stepped up and did in particular. As it moved on and actually people came and kept coming, and the wave kept coming through March, April and May, people were exhausted, people did need to step back. And you know, there was the issue that we saw what was going on across the country, and the moral distress, the emotional fatigue. And really what we knew, it wasn't just about making sure people got a meal deal and got a good lunch, but actually it was looking after their psychological well-being through it, and in the longer term to help them recover. You know, there were some traumatic sights and scenes to be seen. People had a difficult time caring for patients. The lack of family contact has been a really big factor in people's emotional distress going forward in the longer term. But we stepped up and we decided that we needed to do as much as we could as an organisation for our team. And I say team, I mean our 18,000 staff. So here's a really busy slide, but it's just to kind of show the dynamic effort that went on in Guy's and St Thomas's. So we put a bit of science behind our offer, and we realised that people needed to achieve all levels of kind of psychological well-being and safety to feel better and to feel more content in work. I don't think we could fix everything, but we put loads more psychological support in for people. We realised that people needed to rest and their sleep was being affected, so we made available sleep hints. We've got some fantastic sleep physicians, and they gave some really good advice and some really good hints and tips out to people. What we realised is that we moved through and supermarkets were closed as lockdown was on. We opened a staff supermarket. We had many donations, as I'm sure many hospitals did across the country, and we organised ourselves into a supermarket where staff could come and get some of the essential requirements for living, cooking and eating. And that did include a little bit of toilet roll and many tins of tuna. The people that organise the wellbeing, I think it's a bit like the clinical effort. Nurses and doctors moved from all over the organisation and the community. You know, our own staff on Howard Ward in the private patient unit moved into delivering care to patients that was well outside their normal field of practice. They became initially a COVID take ward. They took people through the emergency pathway, looked after some very sick patients, and then as they were deployed out to other wards, you know, the ask of their clinical skills and their experience really, really was big. And the team providing wellbeing, that was nurses that maybe weren't in clinical practice and couldn't go into some of the clinical areas and took the wellbeing role. There were people from our organisational development team, people from our QIPS team, people from communications. It was just a great sense of let's get this nailed and do it. We had loads of volunteers come in and wanting to be in the organisation, and managing that when you don't want to have contact was quite a challenge, but the intentions and the messages were shared out with staff. I just want to go to my notes. So we needed to really build resilience in our staff, and part of that was about providing safe rest zones, safe food, safe place to talk. That's become really, really apparent and really important to people. We've got wellbeing zones across the whole organisation, and indeed we've kept these wellbeing zones now. We're in December, and the intention is that these will stay with us in the longer term, because we realise as we get through this second wave that we're in now, we'll move forward into winter pressures through January, February and March. And actually the cycle of recovery will probably last for people up to 18 months. So as we go forward, we continue to prioritise wellbeing and looking after our staff. Our approach over the next months is more about space, less about having a supermarket, because that's one of the pressures that has diminished in these last few months. But it's more about listening to our staff and hearing how it felt and giving them the space to talk, having our wellbeing zones. We've organised things like wellbeing walks, so people can walk on site and have a little, I guess, respite from a shift if they can step out of their clinical or their work day. Teams have gone back and done some rebuilding exercise, gone back, and actually one thing that we really noticed is that across the organisation there was a really flattened hierarchy, and that everybody worked as a team. And actually some of that is some of what we're holding on to in an organisation and keeping the best bits in place. We're definitely understanding the strong role of compassionate leaders, and that's definitely a model that we're enabling people to learn more about and to practice as they go forward in their team leadership. And for all our individuals, you know, we are a mass of 18,000 plus people, but we are 18,000 individuals that come in and out of work every day to do our best. And knowing what people need on that scale is quite large, so it's about having a really broad offer that will help people all of the way through whatever their problems, and they may well be physical, it may be mental health stresses, it may be financial, it may be someone that's in their life and in their family that actually is affecting how they can deliver and perform at work. So what we're trying to do is provide all avenues of signposting, of support and of activity to help them. I just want to give a shout out to our charity. They've been amazing and supported this wellbeing effort across the organisation. They've just funded, given one of their largest donations into the organisation for millions of pounds to provide about 18 more psychology posts, so people can have longer term support. It's not a one hit. If people need to engage for sessions and for sleep and for anxiety, that support will be available. I just came off our call today with our team brief. I've left you some pictures to show you that amongst some of those dark days through the summer and early part of this year, we still had some fun and tried to inject some good times and some break and some relaxation from some of the grit of looking after our patient load. And now we move forward with a new programme for wellbeing champions. We want people to take on some of the role about providing support and wellbeing into their teams and into their departments. And so we're standing up wellbeing champions. They've got some training and they've got support and resource. It has been a busy year. It's been an incredible year for all of us. But we feel quite proud in Guy's and St Thomas's about how we, not only how well we looked after our patients, but also how well we looked after our staff. So thank you. That's all I'm going to share with you this afternoon.
Thank you, Siobhan. So Siobhan, if I can just drop you on the spot, would you just like to give a really quick update on the vaccines, because I think that may be quite useful for our other colleagues on this call, as to what's happening within our trust and how that will impact maybe the private patient services?
Yeah, so again, like the whole country, the exciting news to hear that the vaccination was approved and ready to roll out. So I've moved over into a support role to get the programme up and running for South East London. Guy's and St Thomas's is one of the first 50 hospital hubs that will receive the vaccination and the drug. So we're organising and helping across South East London the rollout of the vaccination. So as you'll have seen on the news, the priority group first is 80-year-olds plus living in care homes and care home staff. So our programme is looking at the next 2 weeks for reaching out into our patient group first, because they're easy to contact, we have their details, but also reaching into the community, to the care homes facilities that are across Lambeth and Southwark and all of South East London, and ensuring that we've got a registration process, a way for staff and people to make their appointments to come for their first vaccination, and then 3 weeks later to come for their second vaccination. It is a big digital, logistical, human effort to do this from one hospital, from one region, from London and the UK, but it will be fantastic. It will take time, but it will come to all of us. And the only thing I would say is it's going to be free to all, so I don't know that any private activity will happen to supply this to people ahead of the queue. My understanding is the vaccination will only be available kind of in the mass vaccination programme.
Okay, thank you, Siobhan. And I think really on top of that is, you know, are some of our nursing staff going to be pulled from the private service to be able to support the vaccination rollout? And maybe that's a consideration in other trusts. Okay, thank you very much. So We'll now move on. So Siobhan, if you can turn off, thank you. And then I will invite Adam and Laura, I believe is with us also. So Laura is our private patient head of nursing and was very, very much involved in the handover of services to the trust. And herself, along with her entire team, were handed over to nurse the COVID patients that were here. So Adam is going to talk with Laura now around the experience behind that, and we would welcome any questions moving forward. So I will hand over to Adam and Laura.
Thanks, Kim.
Thank you, Kim.
It's I think easy for a lot of us to try and imagine, sort of picture ourselves back just pre-lockdown, because of course we were all together at the last event, which now feels like a lifetime ago. And Kim and Shamila and the others involved organising remember the stress of from one day to the next, not knowing whether we were going to be able to hold an in-person event at the hospital. And I think we had the dubious honour of being the last large gathering of external people in the trust before everything changed. What we really were going to focus on here was that first major lockdown. Guy's and St Thomas's ended up seeing around 1,800 COVID patients. We had one particularly well-known patient, I think, as well, that people will know about. And it actually meant that, as far as we know, we had more than any other trust in the country. And I think that really reflected just how hard South East London got hit first time round. And I think we all expected that as soon as things got serious, that when there was going to be a need for additional space, that our very nice side room only private practice ward was going to be requisitioned pretty early on. But I think nobody was really completely prepared for just what happened over the next few months. And so, Laura, the first thing I wanted to ask you about was, how did you first hear that things were going to happen and that you might get pulled into all of this? And what was your first reaction? What was the staff's first reaction to that possibility?
So I still remember, thanks Adam, I still remember returning from Australia on the 12th of March and came to work the next day, got a phone call about 9:30 a.m. Asking if I could come to the chief nurse office. I remember Kim was on site, so we thought, come along with me. We went upstairs, and at that meeting it was just to tell me, to ask me, Laura, we're going to need your help to basically take on some of the COVID ward and suspected area, basically to support, manage and coordinate. And at that particular time, obviously, we already had a few patients, private patients on the ward. So obviously, both Kim and I said, yes, we're taking that on. By the time I left the office and came back on the ground floor, within the half hour, I was receiving a phone call from the other wards where basically a decision had been made that we were going to convert to an NHS surgical ward immediately. And part of that was to facilitate some of these other wards to be converted into COVID. So very quickly, as I recall it was within an hour. And we transferred patients across the other wards to us. They were more complex patients. It was a different sort of a kind of acuity and dependency, not the kind of patients that our private nurses are used to. So organizing the MDT, so obviously within our private patient ward, we normally have our own doctors who stay on site with us, but right now having all the surgical complex patients, that meant that coordinating the very complex MDT, the pharmacist, because a lot of the drugs that those patients were coming to us with didn't have that kind of stock on our unit. So that was very challenging, but I think the team pulled very well together. So within a week from that, I was then informed as the number of cases started rising within the trust. It was very important for us to convert immediately into a COVID suspected / positive ward. And
And how was, I mean, that sort of was a bit of a game changer, I think, in terms of realization of what was happening. And of course, there's a whole additional implication for staff that you're going to be in direct contact with people who have probably got COVID. How do they respond to that?
So obviously, I have to say I'm very proud of my nurses. I have to say in private patient, in the first instance, just to highlight, we have been supporting the NHS patients within our directorate anyway. But I think in terms of COVID, you know, the nurses were very engaged, but they were very anxious, as you can imagine. It was not just basically because the patients were more acute. They didn't have the right skill set to look after the medical acute patients that the COVID patients were. They were worried about that. They were also worried about their families. The nurses were not so worried about themselves. They were worried about, you know, are we going to take the virus back home with the kids, our elderly? Yeah.
Yeah. And just give us a sense of what the ward, how it ran once it had been established as a COVID suspected ward, because you had your own medical team that actually sat and belonged to you in a way that you didn't previously, didn't you?
Yes, so to start with, obviously within the trust there was very sort of clear command and control of how the COVID suspected ward and positive ward would be managed. So there were teams of doctors of a sort of combination of surgical, medical, respiratory consultants that were going to cover the various ward across the 12th floor, for instance. And so working very closely with the team, the doctors were split across the 3-4 wards, and they based themselves on the ward. So that would be the registrar, the SHO, and the consultant. So there was very, very good leadership at the front line, which provide reassurance to the nurses. So obviously the whole situation with the PPE at that time, you know, was quite challenging. Staff are not used to work within PPE constantly with the patient. So it was a lot of education and reinforcing some of those practices, nursing and both medical nursing and non-medical staff as well.
And our RMO was able to sort of throw their hat in as well, weren't they, as a supernumerary, which was,
exactly.
I think, really appreciated by the medical team.
That's right, yeah. So we sort of asked for our RMOs doctors to join the consultant. They were very welcoming. It was a good learning development for them. And I think then it provided great assurance as well, you know, day and night, that the medics were always on the board with the staff, including the rapid response team.
Yeah. And what were you able to do to sort of help look after the staff and keep them motivated and well looked after? Were you able to tap into those resources that Siobhan told us about?
Yes, we did. So obviously at the front line in the first instance, there was very good leadership. So in terms of, you know, senior nurses, we were always there throughout the day and, you know, feeding back huddles and communicating and answering, you know, listening to some of the anxiety. But beside that, we've sort of had great counseling support for the staff. Siobhan mentioned earlier, there were people that were redeployed to support you know, with the counseling and psychologists. So we benefited from that. At the starting point, staff were a bit hesitant because in a way, nurses and doctors, we always feel we just crack on with it, but we've had to encourage them. So eventually people felt it was a great benefit, and we carried on for, you know, various months as such. So it was great support. And there were, you know, the sort of dedicated areas in the trust. So we were able to release staff to go to some of those areas to have a quiet moment.
Yeah, I think that was one of the things the trust did really well.
Yeah.
I mean, even having, as I recently discovered from our dermatologists, they had roving teams of dermatologists going around to speak to nurses and doctors who had to wear PPE all day to just talk them through skincare and managing that. So really, really great stuff. But whilst that, and the other thing I think was great was the speed at which decision making happened. But what are the things that didn't go so well, and what would you have done differently with the benefit of hindsight, do you think?
I think, I don't know if to say it didn't go well. I think there were challenges in the sense that if I think the first time, as I call it, COVID round one, when we started, in terms of the redeployment of staff, it had to happen so quickly. So beside having COVID patients on our ward, but we've had to support the trust elsewhere. And a lot of our staff were redeployed very quickly, a day from today to the next day. That was quite difficult because you've had people had lives and they had their roster set up, and it caused a lot of anxiety. It was very overwhelming for people. I think this time around there's better planning in terms of the surge that we have. So there's a very sort of clear plan in terms of critical surge, working very closely with the workforce team within the organization, and about the search for wards, basically to the acute ward or the positive COVID ward, similarly with a search for the community. So I think that's definitely, there's been lesson learned there. And obviously what has been put in place, so if you imagine at the time, a lot of the wards, a lot of the speciality had lost a particular ward, for instance in cardiac, and where people didn't know what are we going to go back to, for instance, after the COVID, once you were looking at the recovery phase. I think the anxiety that this caused was very difficult at the time. I think right now people have a better understanding of support within those areas where they're going to be redeployed. So we put sort of extra matron in certain areas such as critical care, so they can go around to make sure the nurses are seen within those areas while they are away from their clinical environment. So I think that's a great sort of learning.
And where are we up to sort of for this round two, I guess? How's the private ward been involved this time around?
So this time around, so within private patients, we continue on supporting some of the NHS patients. The nurses who may potentially, similarly as the rest of the trust, that may potentially be available for redeployment. You know, you provide the names of the staff, you get the fit testing done, and that doesn't mean the staff will be moved as yet, but eventually, if we are required to move, then the nurses will be ready to move. So a lot of the training for the staff have been done already. So we're just sort of basically on standby, I guess.
Yeah. I think my last question, Laura, I just wanted to ask your feeling about this. So I think there's always a concern in PP that we're felt of as sort of a little bit of them and us and not part of the rest of the organisation. And I think what was great is that, you know, no one could claim anything other than PP absolutely mucking in with everybody else in your team, being right there on the front line in the centre of everything. Do you think that's changed the way that you feel PP is talked about or related to across the organisation in the last few months since then?
I think it has definitely, Adam. I think it's been fascinating. I've been here for 2 years, and at the beginning, different journey to what happened this year, really. It's been amazing because of the work and the support that we've provided, both in terms of the inpatient service, similarly with the outpatients, where we supported A&E with their triage. The trust, you know, I think there's a lot of respect for the private patient department directorate, commercial directorate as a whole. There is a better sort of not networking relationship with the tactical operational group to say, and I think we've also supported the antibody testing campaign, which was really amazing post the COVID sort of thing. Acute phase. People now recognize that, you know, PP is always there to help. They always approach us. I think there's also better understanding as to why we can't always take on all the NHS patients on the ward, especially through the recovery. There's a better understanding of how they could work with us. Yeah.
Yeah. So that's a really positive thing, isn't it?
Yeah.
Great. Okay, well, Laura, thank you so much. Firstly, enormous thank you for your leadership during this time. It was absolutely exemplary despite very challenging circumstances. But thanks very much for joining us again this afternoon.
Thank you, Adam. I have to say, whilst we were at the front line, and this is very important for those who are here as a nurse to say, we were here clinically here, but I think it was really great to have my SMT team behind the scene. They were not able to be here on site, but the amazing support that they provided with sort of connecting every single day, it was really a great support for the clinical staff. So thank you.
Thank you. Great. So Kim, going to hand back to you.
Thank you. Okay, thank you everybody. Thank you, Laura and Adam. Hopefully you can stay on. I think Vanessa is going to come back and join us now, and we will go on to our open question and answer session. So if any of you have got any questions you'd like to ask any of us, all of us, then please put your question and answers in the answer box, and Vanessa will fire some questions at us, I believe. Siobhan, I don't know if you're able to join us as well, so we have the whole of us here. Vanessa, I'll hand over to you.
Fantastic, thank you so much, and thanks for such an interesting round of presentations and discussions. I do have a few questions. So the first one reads, what do you believe will be the key to attracting waiting list patients who wouldn't have ordinarily gone self-pay? More flexible spread of payments, etc. Also, what marketing strategy will GSTT be using?
If I can chip in first on the what will attract them, I think it's like always is the case. It's never one thing that does it, or you're very, very lucky if that is the case. I think it's going to be a range of different things. There's going to be different incentives for different people. For some, it's going to be all about the differential in waiting time that's now becoming increasingly apparent. For others, it's going to be having more flexible payments and thinking about self-pay in a way that they hadn't. And I think the marketing probably needs to be a mixture of all of that to try and capture as many different patients with as many different motivations as possible.
I was going to say, I think if we're going to go down that road, you're going to need to consider partnering with colleagues who will deliver well and price fairly and deliver reliably and flexibly. I think the finance options are going to be good, but by region, to look at where the waiting lists are becoming quite problematic is going to be something which is different in each part of the country, and to try and be flexible and have the depth of consultant contacts that you'll be able to deliver whichever part is struggling in your area.
Thank you. So the next question reads, how have the insurers reacted to your reopening?
So if I take this one, so from our point of view, actually we've had a very positive reaction from them. The big questions are our facilities safe? What is the process in line with the COVID testings? And the questions around them, as in, how much more is it going to cost for them to send their patients to us for the COVID testing that has to happen before they come in? So I think the surety there is that we have provided each insurer with our cost for the COVID testing that needs to happen. We've shared with them our COVID pathways, and we are very, very strict in that we adhere to those pathways that are there. If patients want to come to us, they have to adhere to the isolation, they have to adhere to having the testings done. The test results need to come back as negative, and we've shared all of those processes with the insurers, and every single one of them has accepted and been open to that, and are quite pleased in a way. There is a feeling across the insurers that have been shared with us that they are more inclined to use the NHS PPUs. They want to use the NHS PPUs because they feel that they have the expertise, the backup, the services that are there should they have one of their patients that is going to be COVID positive. Whereas we, I think, thought it may be the other way around, that people would want to go to private sector more than come to the NHS, because the NHS is deemed to be that's where everything COVID is happening. It seems to be the reverse of that. From my experience, the interest that we've had from people that are on waiting lists that now want to self-pay and come to us, they want to come to us because they're assured that we have quite stringent, safe processes. So actually it's going to be more safe for them to come to an NHS PPU than maybe it is in private sector. I can't back that up with anything. That's just, the conversations that myself and my team have had with people that have been inquiring. So yeah, interesting times.
Oh, thank you. So the next question is, firstly, we get a compliment, which is fantastic. We get, hi, great webinar, thank you, and very well done. In terms of being able to bring your private patients in, have you been able to recover dedicated private theatre and diagnostic capacities yet, or are you fitting them into lists alongside NHS patients? And how are you scheduling the private demand, e.g. first come, first served, or are you triaging by clinical priority? So
if I start that, and then I'll probably hand over to Mark, Siobhan, Adam, and the clever clinicians in our team, is that we always follow the same process. So it would be clinical priority. And that's the same with the process at the moment. So if we have an NHS and a private patient, if there's a private patient that needs to come in and there is a clinical priority, then that would trump the NHS patient that is waiting to come in for that space. But whereas over to the theatre access and things, I think probably Mark and Laura are best placed to answer those.
So when it comes to theatre access, our standard access has usually been in the evenings and weekends. But as I said, clinical priority is number one. So when it has been that it's inappropriate for a patient to be done in the evening or the weekend, that they are moved earlier into the list or into a different slot with a corresponding counterbalancing action to make sure that everything is fair and above board. Now, we've done some processes in terms of our booking process as well to highlight the urgency of the case, and I've made myself personally more available to my consultant colleagues so that we can discuss these cases and we can get a feel for the urgency and the issues quickly in the context of the theatre environment, and to have those discussions as well.
Is there anyone else that'd like to pick that up?
I think, sorry, one thing that as well that we did very well, I'm sure Mark would say, is basically setting up the pre-assessment within our Directorate. That was very important and quite key within this pandemic, you know, sort of looking at each process critically within an agile mindset to improve our patients through the flow and the various pathway, hence avoiding the delays as well to theatres, and basically so maximizing you know, the activity.
Since we've established that, we've had 0 delays to theatre and 0 reorganisations of an operation, which is essentially maximising what opportunities we have and ensuring a smoother patient pathway as possible.
Just going back to the that original question about how the insurers are responding to this, I think the other aspect of this is the move across to virtual consults, because of course something like 70 or 80% of our NHS consults have now moved across, and it's clearly not going to go back to where it was before, because some people are finding them very useful, and certainly for follow-ups privately. They can be you know, as actually preferable for lots of patients. What was nice is how the big insurers very quickly just put word out that don't worry, they're covered, you can do it. That's, you know, it's better for our members to just get on and do this. But we got, you know, I've certainly seen some absolutely remarkable letters from some of the smaller insurances demanding assurances around a whole range of different aspects of the quality of the consultation that the consultant needs to be able to give in order to say it's okay to then get paid for it. But that noise seems to have died down. But I think as time goes on, it's going to be very interesting to see how long Bupa and AXA, for example, remain comfortable with the way that things are going on virtual consults, especially if they start hearing that people are, you know, turning around consultations in 5 to 6 minutes. I know they're now sort of saying that they have to be at least 10 minutes long, but I think for some specialties where they do very quick follow-ups, this has been you know, it's great for them if they can just spend an hour online and see 10 patients.
Thank you. So the next question reads, at the beginning of the seminar, I think it was mentioned the board and the financial recovery. Have you been set a financial target by the board to achieve from PPU? Have you had any additional financial support from the trust to restart services?
Happy to take that one. Yeah, there's a very big financial target. Whether it's a realistic one or not is another question, because how on earth you predict how PP is going to perform, nobody knows. But I think more than ever there is financial pressure on the organisation, and it's not just less money in the system, but probably most importantly, it's this slightly under the radar switch from payment by results as a tariff of the way that we're reimbursed for activity to block contracts. And for an organisation like Guy's and St Thomas's, which has absolutely driven all of its growth recently by virtue of the fact that we just got paid for seeing more patients, that rug has been completely pulled out from under us in terms of the return to block contracts. So more than ever, there's going to be a reliance on diverse forms of income, of which, of course, PP is going to be top of the list. And, you know, we've seen this played out. You know, I'm going to be honest here, because I'm sure all of you have had this in your organizations as well. There is, of course, a tension between the enormous operational pressures that are being put on all of us on the NHS side, against, of course, the need for a financial recovery, of which private practice is supposed to be a part of. So how do we get the balance right? And I'm not claiming that we've got that right here, but I think this is something that's going to be a significant part of all of our worlds for a while, as there's going to be the jostling for position with the expectations of PP to fill a big gap against the fact that it's never been busier. And not only that, of course, you just can't get patients through in the way that we used to because of social distancing, and vaccine or no vaccine, that's not going anywhere in a hurry. So the next year or two are still going to be, you know, very different. And that's going to be a real challenge for all of us.
Following on, actually, we've got, are you providing more international video conferencing as an alternative to face-to-face consults? If so, how do you indemnify consultants for this?
Right, so we identified this issue early, and I know my colleagues who are doing this more through the GSTT private, and essentially we've gone through the process and I've directed them all to their indemnifiers. We are not indemnifying them. This is private indemnity, which is between them and their insurer, of which there's more than 20 products on the market. So they need to go and make sure that if they don't have cover in their standard product, they are buying the add-on product if required.
So, what business planning predictions are you making for 21-22? Oh, can you hear me? Yes, I think so. Can you hear me? Yes. Okay. So the next question is, what business planning predictions are you making for 21-22?
So I think I'll take this one then. So the truthful answer is we don't know at the moment. So we will look at some form of organic growth. But I think until we understand more about the vaccination rollout, what is going to be the outcome of that, where we can go moving forward. So we will do our usual business planning as we do sort of from our business planning usually starts from the end of December, moving through to sort of March. I think it will be a more challenging process this year, because I know for certain when we did our business planning last year, we thought, oh, COVID might have a small impact, but we didn't realise the severity of the impact on our business it would be. So I think it's completely new ways of thinking for everybody with their business planning, because I think if there's anyone out there that can say they know how the private patient market is going to develop over the next 3 years, 4 years, even 1 year, if they knew that and it was right, they would have the golden ticket to a massive fortune. I think we can all plan our businesses with some small growth and the accommodation of, I think we're going to have to be very insightful and mindful of, there are maybe going to be different opportunities for us now in the new world, sort of post-COVID, and maybe some of the complexities that come out of the back of, people that have had COVID. There are long-lasting effects to their health following on from that. I don't think we fully understand that impact yet. And it may be that there are more diagnostic, more preventative, more services there that we haven't necessarily looked at as such. But I think for the mainstay, I think it will be, our business plan will be as we usually do. We will look at what specialities are appropriate for us to do in the constraints that we have, because I think for the next year we will still have a lot of constraints put on us. But I think there is more of an understanding that for the financial recovery to happen, we have to have the flexibility and be empowered to make those business decisions. And I think as well for us, we're kind of hoping that the decision making that happened whilst we were going through the COVID, first surge was pretty amazing. For a public sector, you usually have to go through 5 boards to get any sort of decision, and then it might change. There were decisions being made like really snappy, within hours. There is no reason why that decision making should change just because we've come out of that. So I think as a group, we're hoping that some of that decision making and organisational behaviour may carry forward, which will help with our business planning. But that's probably just me being the eternal optimist. I don't know if Adam and Mark or Siobhan have any other feelings on that.
I just admire your optimism, Kim.
Ever the optimist.
I would say, well, as I put in my slide, short term, medium to long term, more positive. Short term, who knows?
Thank you so much. I do have a few more questions, and I know how busy everyone is, including our delegates watching. I hope it's okay that I carry on with the questions. Okay with everyone, just for a few more minutes. Fantastic. So the next one is, have you had issues with access to beds in HDU?
So I should probably lead with this one. The short answer is yes. There are ways through it. You need to know who the local leaders of those units are, discuss with them, nursing and medical and managerial, and have an understanding of what's going to happen. Also, there's a conflict between how the NHS works and how the private works in terms of the post-procedural coverage, presuming this is a surgical patient. So you just need to make mitigations for those as well. So in summary, yes, but not insurmountable.
Thank you. How do you stay on top of the changing guidance for your overseas patients? Do you send them weekly updates, or do you have a different process?
Probably another one for me, actually. So when these problems come up, we have a few international patients, but it's not the absolute bedrock of our of what we offer. It's very simple. My colleagues who have it will come to me, and I check in with them, and we discuss, and we see, and we keep our guidance in line with the hospital. And when there's a significant change in guidance, I will reach out and make sure that everyone knows what's happening. We're quite lucky in that we're attached to GSTT, which produces high quality evidence-based guidelines at the drop of a hat. So it's just about being well enough connected to know when they come, and then well enough connected to pass them on to my colleagues as and when they need it.
I think also as well, we have, we're lucky that we have a very good international team. So our international lead, Dr. Elias, he will advise. So he works very closely with the clinical teams, and any changing guidance, whether it be from the nursing perspective or from a clinical perspective, will be shared with all of our international links, and they will do that as it happens. So it may be that they might have an update once a week. It might be that they have a daily update. It depends. When we were going through the real surges of COVID and we had some international patients still with us, the daily processes and procedures were changing on a sometimes hourly basis, so they would be updated as things happened, and that would be both the families, both the embassies, the health offices, anybody that needed to be made aware. The international team led on that, and they continue to do so as well. So we would notify people as they change.
Thank you. So the last question reads, Are all private patients that are being admitted are they being tested for COVID, and would this be administered under the NHS, or do you charge them a private fee for this?
So all of our, I don't know, Laura or Siobhan want to come in on this, but all of our patients are tested. Every single person that comes to the trust will be tested. There is a pathway that they have to follow, and everybody has to adhere to that before they are either allowed to have an appointment to physically come to the hospital or for an admission. For the private fees, they are charged for the testing that happens, and that's just a set price. So we wouldn't use the NHS services to substitute our private activity. So no, there is a fee for, and unless it's an absolute exceptional circumstance, there is always a fee for any private work that is done and carried out.
Thank you so much. So it brings me great pleasure to close this webinar today. It has been fantastic, and I really hope that everyone at home or at work has enjoyed this as much as I have. It's certainly been a real joy to work with Guys and St Thomas's again, and I would like to thank your whole team for the time that you've given so that we can make this webinar happen. So thank you so much, Kim.